Hi everyone, I'm Deja Cole and today I'll be talking about my MSW Program evaluation project. So here's a little bit about my agency. I'm placed at Talbot Hall, which is an extension of OSU Hospital East. Talbot Hall is a substance use / addiction medicine agency, so they deal with substance use. You can get treatment there. In the PowerPoint slides right here in front of you, I listed the different things that they offer. So you have hospitalized detox that's available for alcohol detox, benzodiazepine detox, and opiate detox, so like heroin, fentanyl. They have partial hospitalization, which originally was 25 hours a week, so 5 hours for 5 days a week, but they just extended their hours, so partial is about 6.5 hours every day. Intensive outpatient is 3 days a week with a total of 9 hours, so you go 3 days for 3 hours. They have aftercare groups, so once you're done with your treatment, with partial and or IOP, you will begin like an aftercare education group, and some of them are gender specific, so they have women's groups, men's group. They have different groups depending on what your unique situation is. So they have like a sickle cell group. They have a Fed group, which means like you were federally mandated to be present at Talbot Hall. They have some other stuff going on. They have 1A sessions, so individual counseling. Unless there are extenuating circumstances, you would only be eligible to do 1A counseling if you were done with everything at the higher levels, because Talbot Hall isn't really necessarily a dual diagnosis place. So their thing is that they want to deal with the substance use now, since that's causing you immediate harm, and then we can work on the underlying stuff and the depression and all that, etc. They have the traumatic brain injury case management. So the TBI network that used to be, they were either on Kinnear or Kinney Road. They just merged with Talbot Hall in January, and they do case management for their patients. So their patients have TBI and substance use together, but they also just opened it up to where they have different groups that are open to all people of Talbot Hall, not necessarily just if you have a TBI. And then they have medically assisted treatment options. So that would be your Suboxone for cocaine or opiates. They have Vivitrol, which is an injection, a monthly injection for alcohol to reduce cravings. They have naloxone, and that's the pill version of Vivitrol. They have stuff if you want to stop smoking, and they also do other things. So like above, when I was talking about how they're not really a dual diagnosis center, if you have some depression or something like that, and you speak to one of our nurse practitioners, they will put you on something. So it's not necessarily you have nothing to help with your anxiety or anything like that. So spending time at the agency, I was wondering, wow, what can I do for my project? Does it look like they would need? This is Ohio State. They have pretty much everything, or we would like to think that they have everything. But then I see that that's not really the case. And so my hypothesis is, will providing Talbot Hall patients with community resources reduce stress levels and prevent relapse from occurring? And I chose this as my evaluation question for the year because a lot of times they do only focus on the disease part of the addiction, but then like a lot of the patients struggle getting the treatment, transportation issues. They come hungry, or they leave hungry, or they eat lunch because we provide lunch, and they pack extra because they don't have food to eat later. Some of them are coming from shelters. Some of them are in unique living situations where they are bouncing from house to house. And, whatever other services that they would need. And Talbot has a lot of social workers, surprisingly, but they don't do that. They're like more of the counselor role. And so I was like, okay, there's definitely a need for, some community services or community resources or a little bit more case management within this agency. And since the TBI network came over in January with their case management, I thought about this long before they got there. So with my intervention, I put together a resource book, like a community resource book, and it's pretty comprehensive. Listed here are all the domains. So I have housing things, so like housing agencies here who do like low income or income based scaling. So you have like CPO, Homeport, CMHA. places that do rental assistance, like how Job and Family Services does the PRC. So if you need help paying your deposit when you first get a place, I have information on that. There's information on food assistance, so like different food pantries around the city, some that are geared towards specific zip codes, and then there's others that are open to all. Low-cost community cooking classes. There's this place called Local Matters over in I don't know what you would call the area, but it's over by Children's Hospital, like in the Parsons Livingston area, and they do reduced or low-cost cooking classes. So you can learn how to cook and you can learn how to food prep and do all of those things to make your food stretch. I have information on SNAP benefits and how you will go about applying for those. Clothing assistance, so like different like free clothing stores or places that give you clothes when you're going on like interviews and things like that. Job assistance / reentry. A lot of our patients are coming in and out of the penal system, and some of them are not sure where they can work, especially if they have felonies. So I have information on that. I have information on how you will go about trying to get your record expunged if that's something that you're able to do. I have information on energy assistance, which was a really big thing in the winter time when we had all of those below freezing days. So it would be stuff in there about like HEAP and PIP, which PIP will subsidize your heating costs. So you would basically pay like a flat rate per month on your heating. There's information in there about healthcare, which, you know, just because it's Ohio State and it's in a medical setting, people still don't have primary care centers that they can go to, or they're not sure where their insurance will cover. So there's information on that, and I have information on free clinics in there for them or their friends who don't have insurance, where they can go where it's either free completely or it's on a sliding fee scale. There's things in there about transportation assistance. So a lot of our patients, because they're Medicaid eligible, they may have a certain amount of rides through their insurance. So there's information in there about how they will go about setting those up. There's information about the CODA bus routes, because a lot of time we'll get people who got dropped off or bussed over from like Netcare or something for detox, and they're like, okay, how do I get home? You know, like, I live all the way in Grove City. How do I get home? What bus route do I take? And I noticed that a lot of the counselors, because they drive, they don't really know how to get around with the bus routes. So there's information about that. And then lastly, there's a section where it's just freer and inexpensive things to do around Columbus, you know, because a lot of times people are strapped for cash, or they just don't want to pay a lot to go to places like COSI. So I look and I find things that are either free, like how the museum is free on Sundays, or how with Franklin Park, if you want to go to the conservatory, you can get a pass from the library using your library card and go for free, things like that, so they can have things to do around the city. So here's the cover of my resource guide. It's really colorful. I wanted to draw people in. I started compiling resources the moment that I started at my field placement, and I had my book ready by November, and so I started passing out the full book. But even before then, I was passing out more like time sensitive things. Like I had things in October about like what you would do if you had an eviction and the class was like a specific day in October. Obviously that needs to be out as soon as possible, so I did that as well. And then I did some observations during the November to March time period, which really looked like this. So on the right side of the screen is a daily check-in sheet. All the patients at Talbot Hall use this. It's required for compliance standards, and it pretty much tells you what you need to know about the patient immediately. It's more so for documentation, but we would address it a lot of times in processing and stuff, or just to measure how someone's doing. So it asks you your name, you put the date on it, the number of days sober, which is really important. Date of last use, also very important, because we want to get the patients involved with keeping track of their sober days. And then you start ranking things. So you would rank depression, anxiety, cravings, excitement, and overall life satisfaction on a scale of 1 to 10, with 1 being, not at all, 10 being all of the time or extreme. And so patients would do that every day, and you would kind of get to see like, okay, you know, Jim, your craving scores seem to be really high today. What's going on? Or what was going on last night? Things like that. It asks how many 12-step meetings they went to. So we're talking about Alcoholics Anonymous, Narcotics Anonymous, Smart Recovery, etc. We asked them if they have a sponsor. And if they don't have a sponsor, it's actually a requirement of treatment to at least get a temporary sponsor. And then there's modified questions on here for my research specifically that asks about the resources and if they've been helpful, how many resources they've used, what they would like to see added in the book, etc. And so this is where I'm doing most of my monitoring. And so when I was doing my evaluation project and implementing the intervention, I was looking to see if the depression scores were going down and if the craving and anxiety scores were going down, because a lot of times, people will relapse due to stress. External stressors were the biggest cause, because in early recovery it's hard to develop those coping skills, especially if it's your first time in recovery versus some of our people who have been around and who have done it a number of times. Additionally, I was meeting with patients. A lot of the times I would be running the groups, especially the processing groups where they kind of just process how they feel and things like that. So I would get some more information out of patients from that to get a better scope. And I would also attend regularly scheduled staffing meetings with the care team. So that would be their primary counselor, the nurse practitioner. It might have the psychiatrist, and weekly we would get together and staff the patients. And so I got a lot of good information out of that too, and to see what else could be done. So in my results, I have a few graphs for you guys. So what I did was I had 50 participants, and then for the span of the 14 weeks, I would calculate the average of the different things that I was specifically looking at, because I wanted to see if there was a decreasing trend in the depression and everything. And as you guys see, it pretty much did not change. I mean, it changed a little bit, but not really. So the depression didn't really go anywhere. The cravings kind of went down, and the life satisfaction slightly increased, which was a really good thing. I was happy to see that, if nothing else. But there were some limitations to my thing. I would say that my hypothesis was disproven overall, because the depression and cravings did not decrease. And because they did not decrease, the rate of relapse was still a steady thing. But when you look at the limitations, there were some things that could be considered into why that was. And the biggest thing that I would probably say was that there was inconsistency of patients and data. And I'll say that because a lot of times with substance use treatment, it can be a revolving door. So you may get someone in for 5 sessions, and then they decide that they're going to stop coming. Or you get people who are on probation who come, and as soon as they get the paper signed by us saying that they're in treatment for their PO, they drop out of treatment. So things like that. So loss of patience and inconsistent reporting due to that. I had a very small sample size, so I only had 50 participants, which can be kind of difficult when you're trying to measure to see if this is helpful or not. Everyone's in different stages of recovery. So when you're in partial hospitalization, you may have anywhere from 1 to 30 days. When you're in intensive outpatient, you may have anywhere from also 5, you can have 5 days of sobriety, you can have 94 days of sobriety. So there's a lot of different variants in that, a lot of different coping skills, because someone who's almost done with IOP and ready to graduate will obviously have better coping skills and be able to deal with the life stressors better than someone who is fresh out of detox, only have 4 days sober in partial hospitalization, or so that was definitely something that I took into account. There's this thing called post-acute withdrawal symptoms, which the onset is 24 to 45 days within the sobriety. And it's basically when you first get sober, after you're done withdrawing, you start to feel kind of good. You're like, wow, I'm thinking clearly, I'm feeling kind of better, I'm not waking up hungover, I'm not waking up dope sick, this is great, life is great. At Talbot Hall, we tend to call that the pink cloud. But then eventually you plateau, which is the pause, and you're like, wow, life sucks. Life sucks, I am depressed, I hate this, I'm cranky, I'm irritable, I don't like this. Do I really want to be sober? And a lot of the times, that's when people would be likely to relapse. And when constructing this hypothesis, it was short-sighted. I didn't really consider the pause going on. And lastly, there were changes in counselors for some of the programming, and a lot of times the patients are pretty much used to having the same counselors do things. So when people are switching around and stuff, you know, we as humans, we don't really like change. And that was really hard on them. And there were some reported stressors and relapses where patients said that they relapsed because they didn't feel comfortable sharing with their new counselor, you know, so there was that. And I would say that even though my hypothesis was disproven, even doing this kind of research and compiling these resources, you know, it showed that there could be a possibility in the future for case management or something like that, or a regular employee who maintains this resource guide. Because while I was doing a resource guide, the patients clearly they really enjoyed it. They liked doing the free or reduced stuff where they didn't have to have a lot of money. You know, a lot of times they were taking home extra things or having me make copies so they can give to friends and family. And so there was some really good that came out of it, and I'm hoping that upon presentation and sharing this with the staff at Talbot Hall, that they would at least consider someone keeping up the book after I leave the agency. Because, you know, psychosocial stressors definitely play a big role in what's going on with the patients. If you want to look at the whole patient in its entirety, you have to look at the substance use, you have to look at the mental health, but you also have to look at those outside stressors. You know, even if it's something as simple as, you know, how are they sleeping? Do they have a safe space to sleep? And things like that. So I'm hoping in the future doing projects like this where it's more so geared towards the social determinants of health, that, you know, people will be more willing to address those when coming up with treatment as a whole, instead of just saying, no, you can't come here if you're homeless. To be in this program, you have to have stable housing or anything like that. So, yep, that's my presentation. Thank you all for listening.